be doing my case study on a lateral fan hand projection. So before beginning, I went ahead and pulled up the requisition for the patient. It was ordered on October 9th, 2017. It was a bilateral hand x-ray ordered for a 40-year-old male. So before going to get the patient, I went ahead and set up the room. I lowered the table to a reasonable height. I pulled a chair to the edge of the table. I placed an IR in a portrait position on the end of the table. I then pulled the tube head close to the edge without interfering or getting in the way of the patient being able to sit down. So after this, I went ahead and went to retrieve the patient from the waiting area. Upon arrival into the room, I pulled up his exam. I asked him his name and date of birth. After confirming that I did in fact have the right patient, I set him down in the chair. I retrieved the lead shield, and then I shielded my patient. I then began to ask him why he had come in that day, why we were doing the x-rays, and this is when he told me that he had had some pain and stiffness in his left hand. So after sitting him down, shielding him, and I then placed his arm on his long axis of his forearm, wrist, and hand along the long axis of the IR in a portrait position. I then moved the tube head over, centered it with the IR. The CR I then centered to the second MCP joint of the left hand. I had his hand in a lateral position, separated the third through fifth finger while bringing the first and second finger closer together, then creating a fan. I assured again that it was in a lateral position and that my SID was set to 40. I went back behind the wall, announced that I was going to be taking an x-ray, asked my patient to remain completely still, and then I took the x-ray. For this facility, for a hand x-ray, it is required to do a PA, oblique, and lateral. So I did those projections on both hands, but for today, I'm just going to be talking about the lateral fan projection I did for the left hand. So I went back around after finishing. I asked the patient if he had any questions or concerns. He did not. I moved the tube head out of the way, took the lead shield from him. I explained to him that the doctor would be getting these results very soon and that they would be in touch. And then I walked him back to the waiting area and thanked him and told him to have a good day. I then returned back to the x-ray room. So according to Bontrager, the criteria for positioning for a lateral fan hand projection, the entire hand should be included, as well as 1 inch of the distal forearm. The fingers should be equally separated and in a lateral position parallel to the IR to ensure that the joint space is open. The thumb should be in a slightly oblique position and should also be free of superimposition. The radius and ulna should be superimposed, as well as the metacarpals should be superimposed. The CR should be centered to the second MCP joint of whichever hand you're doing. You should, of course, have optimal density and contrast for the image. You should be able to see the soft tissue area, and you should be able to see the sharp bony trabecular markings of the bone. You should have the correct marker in the lateral border of the anatomy of interest. You should have a 40-inch SID with no grid needing to be used. You should set the appropriate technical factors for a lateral hand projection. The patient should be supine if possible, with the hand and forearm extended. The patient should be shielded properly, and there should be collimation on all four borders to the anatomy of interest. So this, as you can see, is my left hand projection, lateral fan projection. So just to name some of the anatomy here, I'm going to get a little bit closer so you can see. So here we have the distal flanks of the fifth digit. This right here is the middle phalanx of the third digit. This right here is the sesamoid bone of the first digit. Here we have the first metacarpal. This is the trapezium. This is the scaphoid. This is the lunate. Here we have the radius. Here we have the ulna. And then right here is the ulnar styloid. So that's just some of the anatomy that you can see and should be seen in a lateral projection of the hand. Now, as far as corrections that needed to be made, you can see that it is not in a true lateral position. And you can tell this by, first of all, the ulnar and radius are not completely superimposed. You can see here that the ulna is seen posteriorly to the radius, which indicates that this was not properly rotated. It was actually under-rotated. You can also see that the metacarpals are not completely superimposed, which again indicates that there was not proper rotation of the hand to where if they were in a true lateral, they would be more superimposed. So those are just a couple of the corrections needed. You can also tell by these white border margins right here that my anatomy was not completely lined up with the long axis of my anatomy was not lined up with the long axis of the IR, because after the exposure was made and adjusting the image, it needed to be rotated to be more up and down, seen by, so the radiologist could see it more in an up and down matter. My marker is in the correct spot though, the left lateral margin of the anatomy. I'm sorry, the lateral margin of the anatomy, and the left side marking the correct side. So those are just a few of the corrections that would need to be made. For as far as technical factors, you can see here on the, maybe on the other one, right up here, that for this facility, for a lateral hand projection, it is set at 64 kVp with at 6.64 mass, sorry. That's what the machine is set to. Now, it turned out pretty well. You get some good contrast, some good coloring, and good brightness and density. As you will see sometimes the distal flanks of the fingers a little bit overexposed sometimes, a little bit sharper looking, but that is expected to be seen. So right down here you can see the EI number, sorry. You can see the EI number is at 200. The EI number is the exposure index for the machine you're using. I was using a Philips machine, and the EI should be anywhere between 200 and 800 on the machine I was using. The EI on this came out to 200, which tells me that I had an image that was acceptable, and so that is a good thing. There are no visible artifacts to be seen on the image. Here we go. And as far as the impression of the radiologist, there was no, the patient came in suspecting some sort of arthritis because arthritis has symptoms of inflammation of joints, joint pain, joint tenderness, some swelling. These are all signs of symptoms of arthritis. After the radiologist looked at all the images, there was no arthritic evidence or developmental abnormalities that could be discerned. So there would be more exams that would need to be done, blood work and things of that nature. So do you know, there's lots of, after being in this facility, I learned that there was lots of things that have the same symptoms as arthritis, and our minds usually go to arthritis because we know those symptoms. So I think it's important to know other things it can be, even though we're not the ones that are telling the patients what they have. It's just good to be and to know the different signs and symptoms of different diseases. Do you know any symptoms that are the same as arthritis as far as joint pain, stiffness, swelling of joints? Just to name a few are lupus, gout, fibromyalgia, and even Lyme disease can all have the same kind of symptoms. So unfortunately this gentleman, well, fortunately he did not have arthritis that could be detected. Unfortunately he did not have any answers at that time. but I know that they will run some more tests and hopefully get some answers for him. So that's it for my case study. I appreciate very much you listening, and I hope you have a great day. Thank you.